PND, Paroxysmal Nocturnal Dyspnea. I am now going to discuss Paroxysmal Nocturnal Dyspnea, a significant symptom often encountered in patients with cardiac and pulmonary conditions. PND is a distressing experience when a person wakes up suddenly at night gasping for breath. It indicates serious underlying pathophysiology, primarily linked to the heart failure and pulmonary congestion. So, how will you define and what are the difference from orthopnea? PND is a sudden, severe shortness of breath that wake up a patient from sleep after requiring them to sit or stand up for relief. Orthopnea, on the other hand, is a dyspnea occurring when lying flat and relieved by sitting up. Unlike paroxysmal nocturnal dyspnea, orthopnea is immediate, whereas PND occurs after some time, that is minutes or hour after the sleep. Sleep due to the progressive pulmonary congestion. So let's talk about the pathophysiology of paroxysmal nocturnal dyspnea. So PND is primarily seen in left heart failure due to increased pulmonary venous pressure and interstitial fluid accumulation. The key mechanism includes first, redistribution of body fluid. When lying down, venous return increases, raising the left ventricular preload, causing pulmonary congestion. Second, reduce sympathetic tone in sleep. At night, there is a parasympathetic dominance and decreased adrenergic stimulation, leading to reduced myocardial contractibility. Third is a increased vagal activity. Causes bronchoconstriction further exacerbate the feeling of breathlessness. And the fourth is a impaired lymphatic drainage. During the day, lymphatic clear excess pulmonary fluid, but at night this function is reduced, causing interstitial fluid accumulation. So let's talk about the causes of the paroxysmal nocturnal dyspnea. First cause is a cardiac cause, and which is most common. That could be a left ventricular failure, LVF. There could be a congestive heart failure, that is a CHF, mitral stenosis or mitral regurgitation, mitral valve stenosis or mitral valve regurgitation, aortic stenosis, aortic valve stenosis or aortic regurgitation, dilatation or restrictive cardiomyopathy. Hypertensive heart diseases. Second cause is a pulmonary causes. Chronic obstructive pulmonary disease, also known as COPD, pulmonary hypertension. Obstructive sleep apnea, that is OSA. Interstitial lung disease, also called as ILD, and pulmonary embolism, that is PE. Other causes are obesity, hypoventilation syndrome, severe anemia, renal or kidney failure in which fluid overload state. Now, clinical presentation and diagnosis. The symptoms are awakened suddenly with breathlessness, often gasping for air. It may experience a cough with frothy sputum, sign of pulmonary edema. Feeling of suffocation, needing to sit up or open window for relief. Associate with chest discomfort, palpitation and sweating in cardiac causes. So, on clinical examination, crackles, that is a crepitation on auscultation, which suggests pulmonary congestion. S3 gallop, which also suggests heart failure. Peripheral edema, there is a raised jugular venous pressure, that is a JVP raised, indicate fluid overload. Orthopnea present in severe cases. Under investigation, first investigation is the ECG to assess for ischemic heart disease or arrhythmia. Second is a chest X-ray, in which cardiomegaly, pulmonary edema, that shows Kelly's B lines. Third is a echocardiography. It is essential to assess left ventricular function, valvular heart disease, BNP level, that is a biomarker for heart failure. Pulmonary function test, PFT, if a respiratory cause is suspected. Treatment and management. First is a immediate relief measures. Sit the patient upright, reduce venous return, supplemental oxygen if hypoxia or SpO2 level is less than 90. Diuretic, for example, furosemide. It will rapidly reduce the pulmonary congestion. Nitrate, for example, nitroglycerin. It reduces preload and pulmonary congestion. Second is a long-term treatment based on causes. Cardiac cause, ACE inhibitor or ARBs reduce afterload. For example, ramipril, losartan, beta blocker reduce myocardial oxygen demand. They are metoprolol, diuretic, controls fluid overload. For example, spironolactone and furosemide. Digoxin, in case of heart failure with reduced ejection fraction. Now the pulmonary causes: bronchodilators and steroid for COPD and asthma, continuous positive airway pressure CPAP, obstructive sleep apnea, pulmonary vasodilator, pulmonary hypertension, lifestyle modification, fluid restriction and salt restriction in congestive heart failure, weight loss if obesity is the factor, regular exercises and cardiac rehabilitation, smoking and alcohol cessation. Prevention and prognosis in this condition is early detection and management of heart failure is a key. Regular monitoring of ejection factor, that EF, in a heart disease patient. Adherence to medication and lifestyle changes improves long-term outcome. If untreated, PND indicate worsening heart failure with high morbidity and mortality. So let's conclude. PND is a warning sign of significant cardiovascular or respiratory disease. From diagnosis and targeted treatment, improve patients' outcome or survival. Patient education and lifestyle modification are critical in preventing recurrence. Early referral to a cardiologist or a pulmonologist is advised. In recurrent or severe cases. Thank you.